bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities: again. It is a real pleasure to welcome back today's panel to the CAFC Presents virtual stage. You will recognize all of the names from some of our very first webinars that we produced back 4 or 5 years ago with what was at the time the CIHR team in children's pain. And you'll notice the title, Taking Stock, indicating that we're taking a look back at some of that great work that was generated by that team and seeing what's happened since then as the group, while the team has completed its objectives, the various members are still continuing their great work in the field of children's pain, still collaborating. So it's great to hear what's happened since then and a little bit about where the future of children's pain is heading, or the research on this topic is heading. So it's my pleasure to introduce once again to the CAFC Presents stage Dr. Bonnie Stevens, who is the Signe Hilder Eaton Chair in Pediatric Nursing Research, Associate Chief Nursing and Research, and Senior Scientist in the Research Institute at the Hospital for Sick Children. She's also a professor in the Lawrence S. Bloomberg Faculty of Nursing and Faculty of Medicine at University of Toronto. And she's also the director of the University of Toronto Centre for the Study of Pain and co-director for the Centre of Pain at the Hospital for Sick Children. Following Dr. Stevens, we have Dr. Denise Harrison, who is the chair in nursing care of children, youth, and their families at the University of Ottawa and the Children's Hospital of Eastern Ontario. She's produced a number of much research around the topic of Be Sweet to Babies, which is focused on improving pain management for sick and healthy infants and young children, and has produced a number of videos, which she's going to share with us during this presentation. And following Dr. Harrison, we have Dr. Christine Chambers, who is a clinical psychologist and professor in the Department of Pediatrics and Psychology and Neuroscience, with cross appointments in anesthesia, pain management, and perioperative medicine and psychiatry. She's also the former Canada Research Chair in Pain and Child Health, and she comes to us from Dalhousie University in Halifax, Nova Scotia. So once again, it is my pleasure to hand the virtual podium over to Dr. Stevens.
Thank you very much, Doug, and thank you to everyone at CAFC for inviting us back. As you said, time goes by quickly, and a lot of evidence has been produced in pain in children, and what we really want to focus on today is ways of using that evidence. So all children continue to experience pain through newborn screening and immunization procedures. However, for children that are hospitalized, procedural pain is much more frequent and much more intense as they receive diagnostic and therapeutic procedures. Although we've generated a lot of research on interventions to relieve pain, including pharmacologic, psychologic, and physiologic strategies, much of that evidence is either not effectively translated or usable to healthcare professionals at the front line who provide care to these children and their families. As an example, if we look at infant pain research studies from 1980 to the present, we can see that there's been an exponential growth in the number of research studies that have been produced. So the goals of this webinar are to review the current state of evidence for preventing and or ameliorating procedural pain in hospitalized children or healthy children receiving painful procedures in the community. We'll describe our various efforts to effectively implement research evidence into practice using both infant and toddler and school age and adolescent populations. And finally, we want to strategize how evidence can be made more usable for healthcare professionals and parental care providers. So I'm going to start off by talking to you a little bit about the shifting of the paradigm from evidence generation to translating of evidence for practice. As I said, all children have pain for disease screening and prevention. However, hospitalized children have many more procedures. We recently, in our CIHR Children's Team Grant, showed that in Canadian hospitals, children have an average of just over 6 painful procedures every single day, and the range is from about 0 to 450. So that's a lot of pain that we are actually introducing these children to. Since the 1970s, we've really focused on a lot of research, and there's been a proliferation of evidence-based pain management guidelines developed from newly generated research. However, this evidence hasn't been used effectively in practice, and the challenge for us now is really to find ways to make research evidence usable for healthcare practitioners through effective knowledge translation strategies. So when we think about knowledge translation, we actually are introduced to a real plethora of terms, and we hear things like knowledge transfer, implementation science, innovation, evidence utilization, and adoption. And this wordle really reflects the frequency with which we're now hearing these terms, with the bigger ones being the more common. So there's lots of terminology out there, but the general idea underlying this terminology is that we'll find an effective and efficient way of taking what we learn from research and putting it into practice. So as I said, we need to shift the paradigm or shift our thinking from effectiveness to implementation research. In effectiveness research, we're trying to figure out how well does something work. So how effective is an intervention in changing an outcome? So for example, how effective is sucrose in decreasing pain in infants during immunization? And we measure effectiveness by looking at various types of behavioral and physiologic responses to the painful stimulus. Whereas in implementation research, we really want to know how well can we implement research into practice. So how feasible or easy is it? Are these strategies acceptable to the various users, whether they be healthcare professionals or parents? How costly is the intervention? Is the intervention implemented as it's designed or in a fidelity sort of way? And if we're able to change how healthcare professionals or parents manage pain, will it be sustainable over time? So in our CIHR Team Grant, we looked at a novel knowledge translation strategy. It was called Evidence-Based Practice for Improving Quality, or EPIC. And it was an interactive, multifaceted strategy that merged evidence, identified potential practice changes, and involved a collaborative of interdisciplinary health professionals who implemented tailored KT strategies to improve patient care using continuous quality improvement. EPIC involves 2 changes and is based on a conceptual model. It's called the Paris model, which really looks at the interface of strong evidence, favorable context, and a facilitation strategy in changing outcomes. The intervention steps really refer to preparation for change, establishing change council, training them, reviewing baseline practice data, reviewing existing clinical and research evidence about the change, and then really narrowing in on deciding on a practice change. In the implementation phase, there is a test done of the practice change, and then these changes are implemented in practice using a plan, do, study, act cycle that is repeated multiple times and then monitored in terms of how well we're achieving our aims. There's various types of KT strategies that we use. The most common is reminders, so any intervention, whether it's manual or computerized, that prompts the healthcare provider to perform a clinical action. So these could be email messages, buttons, screensavers, all kinds of things. Then we have other KT strategies, including educational materials, educational outreach, and using audit and feedback to summarize clinical performance over a specified period of time, and then providing feedback and recommendations for clinical actions. So did EPIC work? Well, EPIC did work in terms that it improved the proportion of children who had pain assessed using validated assessment tools. It also improved the proportion of children who received analgesics for procedures, and it also improved the use of physical pain management strategies over time. We also wanted to look at whether EPIC was successful in reducing the amount of pain children had. And we did find that on the units where the EPIC intervention was introduced, that the children were much less likely to have severe pain compared to children on the standard care units. And so the odds of having severe pain were 51% less for those in the EPIC units. We also found that all age groups except infants were significantly more likely to have severe pain compared to adolescents. So this is really showing that EPIC was an effective intervention at improving pain practices. However, EPIC was less effective in terms of implementation outcomes, as it was not really feasible to do this without resources and time and a research nurse. And of course, that was costly. And without those resources, the sustainability of an intervention like this comes into question. So we really felt that although we learned a lot, we need a KT intervention that's both effective and easy to implement. And we learned this. This is a very nice knowledge translation strategy that was led by my postdoc at the time, Kim Widger, that reflects the stories from the floor, the stories from the research nurses in what they learned in trying to implement research into practice. And some of their key learnings were that they needed to build relationship with staff based on trust and shared understanding. They needed to involve the right people to lead the change and actively engage staff through all steps of the process. They said we needed to focus on seamless integration of targeted practice in the workflow, and we needed to have an intervention that was simple, easy to implement, flexible, and resource efficient. And finally, they told us not to try and accomplish too much at once, but to take baby steps. So we took what we learned from the research and from the research nurses who did the stories from the floor, and we've now developed a future knowledge translation strategy that we call the Pediatric Pain Implementation Toolkit. So this toolkit really focuses on how you implement research into practice. Many toolkits are simply a compilation of measures and guidelines, etc., but we know that those won't work unless we have a strong strategy for changing the behavior of healthcare professionals. So we have outlined 7 steps to changing pain practices. The first really looks at readiness to change, creating a change team, looking at current practices, being clear in identifying a practice change, and then we go into the cycle of plan, do, study, act. So I'll just share a few of the screenshots from this web-based toolkit. So the first is really doing a good evaluation on determining if the unit is ready for change. And we do this through a tool and a series of questions that help look at practice in the practice setting, and also information about the context in which you're trying to make the change. And this work is largely adapted from the work of Carol Estabrooks, who developed a tool called the Alberta Context Tool to assess context. In the next step, we really want to be careful about creating a change team. And this needs to be a team that is supported by the leadership. It consists of people who can influence practice. People need to be from different professions and positions within the team. We need to include members who are enthusiastic and have shared ideas, and also staff members with skills and knowledge that complement each other and that are dedicated to this process. In steps 3 and again in step 6, we've developed an automated audit tool. And this really helps us review patient chart data to see exactly what is being done, both in terms of painful procedures as well as strategies to relieve or prevent that pain. We do this on an individual basis, and then we can roll this information up to information that can be stated at the unit level. In stage 4, this is where the pain practice goals are set, and we really are asking groups to focus on either an assessment or a management goal. Within this step, all of the potential assessment tools and their validity and reliability are housed, so people can really take a look at all of this and select what they would like to focus on. And finally, we get to the implementation or change cycle, and this is where we really introduce all of the knowledge translation strategies. And you can see here an example where this group has decided to introduce a poster and workshops and buttons, clearly states who's responsible, when they'll do it, where these strategies will be housed, and how well they did with it. And I'll finish up, this is by showing you, many of you may have seen this before, but these are some of the KT tools that we use. These are some of the reminders, educational tools. The daily CIP huddle board is really looking at an interactive educational strategy, and of course we used audit and feedback. So I just want to summarize by presenting you with a brief case study to try and highlight what we've been talking about here so far. So this is a study with a mother and father who bring their 6-year-old into the hospital emergency department. He was tobogganing with his sister, fell off the sled, and appears to have broken his arm. The parents are concerned as he appears to be in a lot of pain. They ask for pain medication, and there's 2 potential scenarios that might follow. The first is the healthcare professional says, we don't know what is involved here, and we'll need to wait for the doctor to see him before we can do anything. We don't like to give them anything in case it masks the symptoms. I don't know whether that sounds familiar to you, but in my practice scenario, that this is something that is quite common. The second scenario is the nurse or physician says, of course he's in pain. Fractures are painful. I have assessed his pain and you are right. It seems to be severe. I'm going to get the doctor to order him something for the pain right away. In the meantime, it is helpful if you can distract him with a few things from this pain toolkit. So I just wanted to ask you, poll the audience, which of these scenarios do you think is most likely? And will the parents demand to see the doctor and get something right away to make their child more comfortable? Or will they acquiesce and allow their child to suffer until the doctor arrives?
So if we could just get the audience to just type into the question box which answer they or which scenario they think is most likely. And we got the first few people. It's almost 50-50. People saying demand to see the doctor versus acquiesce.
Yeah. Well, I think that is a sense of reality because, again, I think that although parents and healthcare professionals do not want to see their children in pain because parents don't have a strong awareness of what is available for their child, they often do sit back and wait. We also, though, have parents who are becoming more and more knowledgeable who would have better knowledge and awareness of the evidence that would actually move forward and be more assertive in ensuring that their child is not in pain. So I think it's an everyday kind of example, and I'd like to be able to change the situation both from the response that the parents receive from the healthcare professional and also the parent's role in moving ahead to ensure that they're good advocates for their child. So I think, Doug, I will stop there unless there are any further questions.
All right. Thank you, Dr. Stevens. There haven't been any questions yet. Lots of responses to the question about the scenario, but no questions for you at this point. But that's certainly my opportunity to remind the audience to type your questions in as you think of them. And if you do have questions for Dr. Stevens, we'll certainly come back to those at the end for sure. So now we're going to move from Toronto up to Ottawa with Dr. Denise Harrison. Over to you, Dr. Harrison.
Okay, thank you very much, Doug, and thank you, Bonnie, for that excellent presentation. So my talk moves on from that presentation and really focusing on usable evidence and reducing pain in babies. Okay, so my focus of research for quite a few years now has been pain management in neonates, infants, and young children. So my aim really has been moving from this scenario where when I began my neonatal nursing career, I could tell which room the phlebotomists were in by the babies screaming. As I walked down the corridor, I knew the phlebotomists were in room 4 or room 3 or room 2. So I really wanted to move from that scenario to this scenario where the babies were having painful procedures and not crying because effective evidence was being used to reduce their pain. So first of all, we are moving on. So usable evidence is really taking all the trials, starts at taking trials which have been done and synthesizing the evidence. So this is just an example of synthesized evidence as it relates to sweet solutions. So you can see up here Sucrose for Newborn Infants by Stevens et al. The last big update of that review was completed in 2013. They included 57 trials with nearly 5,000 infants. So instead of us nurses and physicians needing to read 57 trials, we can at least now read one systematic review. However, this systematic review is excellent, but it's also 144 pages. So it's excellent, it's good synthesized evidence. It really is a way to pull all those original individual trials together. It's still a very large document. So we need to move further to make this document usable to the people at the bedside who we hope to use this evidence, and also for parents who we hope will help advocate for their children. So this page is all to do with sweet solutions, and in addition there's other pain management strategies. So, I'll just go back a step. So this figure is this usable evidence. And so this is, again, just the sweet solutions, and it's data I'm working on now that combines all trials and outcomes of pain assessment scores. So certainly for epidemiologists, absolutely, this is usable evidence, but it's not something that most mothers at the bedside, fathers and nurses at the bedside will really see, really helps them provide that evidence at the bedside. So as I said, this evidence is just relating to sucrose. But there's other strategies. So skin-to-skin care. Now there's another large systematic review published last year that included 19 trials. Breastfeeding or breast milk for newborn infants, a large Cochrane systematic review that included 20 trials, and non-pharmacological strategies, and also a systematic review on music. So there's a lot of evidence out there that has been synthesized into at least a form that all the trials are contained in one document. But we need to move on there, as I said, to make it really usable for the users and the parents. So one thing that we need to do is to further synthesize that evidence into summaries and guidelines. So this is a document that was a paper that we published last week, myself and my Be Sweet to Babies team, and Mariana Bueno in Brazil, who was also a student of Bonnie Stevens. So at least this paper is a very brief, it's just 8 pages, and it really pulls the evidence from the 3 systematic reviews of breastfeeding, skin-to-skin care, and sucrose into one paper. And it's a very broad, I guess, overview of these strategies and how we actually can apply these in practice. So that is one step further into making the evidence usable. So I talked about the Cochrane systematic reviews and the sucrose one being 144 pages. So Cochrane have been pretty clever into really further synthesizing these large reviews into summaries. So I'm just going to click on this link here to take you to the breastfeeding summary. It's just taking a while to open. Here we go. So this is further synthesizing the evidence from the breastfeeding or breast milk Cochrane systematic review, and you can see now that it's actually only one paragraph. So it's really summarizing the absolute key endpoint of the evidence relating to this systematic review. And Cochrane have put out these summaries for most of the pediatric pain reviews. So this is becoming much more usable, at least to people who access Cochrane. And so again, for parents and for staff at the bedside, if they find Cochrane and if they can get to this evidence, this paragraph is certainly much more usable at the bedside. Sorry, I'll just get that. So then, as Bonnie said, there's a number of clinical practice guidelines too, which are really aimed at providing guidelines for care at the bedside. So Grace Lee last year reviewed all the guidelines relating to acute procedural pain, and there's now 18 out there. So certainly we've really aimed, a lot of us who are dealing with children's pain, at producing high-quality evidence-based guidelines that can be used at the bedside. Then we move further into evidence summaries. So these are examples that I've done, and we hope to use these for future studies. And so these are obviously targeted at healthcare professionals and not parents. So they're one-page evidence summaries that really pulls all that evidence together into one page, but yet still rigorous in the fact that we give the references, we give the background, we give the question. And so it's really trying to get that evidence into practice, but still with that scientific framework. And then we're moving further to posters. So this is one of the educational products when Bonnie talked about educational outreach, educational products or reminders. So these posters I developed when I was working with Bonnie Stevens at Sick Kids to really profile sucrose in French and English in a way that really helps people to have a quick look at the poster and use that evidence in practice. Then I went further, because that is just sucrose. So if you're going to promote sucrose breastfeeding and skin-to-skin care, well, then you need 3 posters. So we really needed to further synthesize that evidence in an attempt to make it more usable. So we have 1 reminder to use breastfeeding, kangaroo care, or sweet solutions. And then 1 poster, again, with that bit more information, but still there in 1 easy-to-read poster with all 3 strategies. So these are in process. We haven't used these in practice yet, but we're certainly planning trials to use these as the healthcare targeted interventions to improve pain management. But there's still challenges to practice, so especially when it relates to maternal care. So I've said on the posters, use these in practice, but then again, there are still questions and challenges that the nurses and the phlebotomists and the parents bring up. So as I said, these relate to breastfeeding and skin-to-skin care, the maternal-led interventions, and these practical challenges really relate to timing of bloods. And we really have this routine that bloods are done in the middle of the night or very early in the morning. So it's really trying to get to the point of that. Is that really necessary? Like, why not do them at the evening before for these non-urgent bloods, so we still have the results for the morning ward round? And these non-urgent bloods in stable babies, they're not going to change in those few hours if we do them at 4 in the morning rather than 11 p.m. at night. Certainly for ergonomics, we do need low chairs or stools for the clinicians performing the procedures, which sounds easy. I mean, they are easy to provide, but it's really putting that up there that that's what you need to do, rather than the phlebotomists and the nurses and physicians who are doing these procedures putting these barriers up at the start. There are some beliefs too that the procedure will take longer to perform, or the mother doesn't want to be there, or the infants will associate mother with painful procedure. So these are beliefs that are out there and may be resulting in barriers to using this evidence into practice. So based on that, I've been thinking for a long time we need to actually show the evidence, and that will help to really show that these strategies do work and that they're feasible to do, and in terms of the nurse too, that these strategies are practical. So I'm just going to open this video and just show you a few minutes, not all of it, because it's quite long.
3 things are most effective: breastfeeding, sugar water, and kangaroo care, also known as skin-to-skin care. Breastfeeding can provide much more than nourishment to babies. It can also help reduce their pain and distress from blood tests. As you can see in this video, the nurse pricks the baby's heel for the blood sample while the baby is breastfeeding. As a mother, you can help by holding and breastfeeding your baby while the blood sample is being.
And I'm also going to mute it. You do have the link to this video. So basically we show breastfeeding, then we move on to skin-to-skin care while the baby's having a heel lance. And then finally we move on to sucrose. I'm just having a few mouse issues. Sucrose with non-nutritive sucking during a venipuncture. So this video is on publicly available on YouTube, and so it's one way to really finally get to that end point, how I see, of making the evidence as usable as possible. And we know that the best thing is to show things, how things work. So I just felt all these years I've been talking, more words, writing, doing posters, which certainly help. But this is a way to reach a broad audience and to actually show the evidence. So that's what I showed you was only in English, but of course there's other languages out there. So we have produced this video in English and French and Mandarin and Portuguese and Spanish, and we're soon to have the Arabic video released and Inuktitut to get to our northern communities, as well as sign language. So hopefully then we'll have a really nice, easy to watch, short, it's 4 minutes in English or 5 minutes in French, way to actually see that we can effectively use breastfeeding, skin to skin, and sucrose for pain management. And of course that's fine for the little babies, but the babies grow up. And so we've also produced, well over a year ago now, a video showing infants having their 2-month immunization and being breastfed, which you can see in this screenshot here, and a 6-month infant having sucrose during their immunizations. So again, this has been up on YouTube for over 12 months, and this is actually being watched extensively. But our next question, of course, is, does that actually change practice? So the neonatal video, we've actually done a pilot study in the neonatal intensive care unit of 50 parents, and that certainly did show an increase in knowledge and a very high intent to use the strategies. But the parents said it needs to be shown soon after admission rather than days down the track. So we still need to look at, does that video actually result in increased use of these strategies during the baby's heel lance? So the infant vaccination videos has now had over 75,000 views, so it has extensive reach, but does it actually have impact? And so only 162 online surveys were completed, so it's probably the lowest response rate ever known to man. And so we actually really couldn't use them to evaluate impact. And does this video really improve practices in the diverse settings where babies have injections for immunizations? So again, I have a brief scenario. So a mother brings her 2-month-old baby into the pediatrician's clinic for the 2-month immunizations, and she asks the nurse if she can breastfeed. So 2 scenarios may follow. One, that the nurse says, excellent, she, says begin feeding now, and the baby will be well latched on by the time she's ready to give the immunizations. Or, I've not heard of this practice, can't see how this will help, your baby might choke, it's awkward for me, and you can feed after I've finished. So many mothers tell me these stories, and I've heard both responses. So what scenario do you... Sorry?
I was just going to say, for just to let them know that we do have an actual poll for this scenario, so we can ask the audience to click on the screen and make their choice about which they think is the most likely of the 2 scenarios that they just heard.
And if you do that, then just think of the second scenario and the mother's response. So do you think the mother will advocate for her baby and state she will breastfeed, or acquiesce and allow her baby to have the injections with no pain relief?
We can see that most of the audience thinks that scenario 2, that the nurse will say, I have not heard of this practice and cannot see how this will help. 77% said scenario 2. So if we move on to the second part of that question about what do you think the mother will do? Will she advocate for her baby and state she will breastfeed, or will she acquiesce and allow her baby to be immunized with no pain relief? And for those of you who are typing in your responses into the questions, you can click on the screen and make your selections there, and it will automatically go in. So we can turn this one around, and we can see that most people, 78%, feel that the mother will acquiesce and allow the baby to be immunized with no pain relief.
Thank you, Doug. So you can see that we've really still got more work to do to help parents be advocates, and also to change our own practice as nurses and physicians and phlebotomists doing these procedures. So I'd just like to summarise that babies need us to help reduce their pain, and breastfeeding, kangaroo care and sucrose effectively reduce pain in young infants, and breastfeeding and sucrose in these older infants during immunisations. And I'd just like to acknowledge the Be Sweet to Babies team the CHIO Foundation, CHIO Research Institute, and grants from the IASP and Canadian Pain Society, and especially Bonnie Stevens for all her support over the years, and Sandy Dunn from Vaughan for all her support. And thank you very much, and my contact details are there, and I'm happy to be contacted by any of you out there. And thank you.
All right, thank you, Dr. Harrison. We do have a few questions. While we're in the process of handing over to Dr. Chambers, we'll just take a couple of quick questions. The first question came from Allison, and she's asking, are these the practices that you were referring to, the 3 practices around sucrose, kangaroo care, etc., are these practices applicable to NAS babies also?
Absolutely. So in the past, let's go back a step. NAS babies in the first days of life have altered endogenous opioid systems. So the way sucrose works is it increases endogenous opioid release, and if those systems are very low to begin with, sucrose may not work as well in the first couple of days, but these babies do normalise, and more recent studies by James Marceau in Australia has actually shown that sucrose does work in these babies. But that's something that you'll need to work out, and it is very individual. Some babies sort of normalise, and by a couple of days, the sucrose you can physically see really helps them, whereas others, it really doesn't. And so certainly we know that non-nutritive sucking really helps. The contact of breastfeeding and skin-to-skin care really helps, and we can see that by these babies are much more settled when we've got them upright, skin to skin, and walking around with these babies and patting them on their back. So just keeping them close and sucking really helps them.
NAS, I'm assuming we have a large and diverse audience. Not everyone may know, but maybe you could just quickly tell people what that is.
So narcotic abstinence syndrome. So it's really mostly when mothers have been put onto methadone to stabilise their heroin use or other medication use during pregnancy, and so it keeps the mother much stable and the fetus growing nicely and keeps the mother safer. But unfortunately, many babies have quite severe withdrawal symptoms. So it's managing those severe withdrawals when the babies are born. And the main thing is really helping them suck. They desperately need to suck. So suck and keep them close, but yet cool. They don't like to be overheated. So it's really focusing on comfort measures, keeping them close, keeping them upright, keeping them sucking, and certainly when they need procedures to still use these 3 strategies in practice.
All right, thank you. Well, we'll take one more question before we move on to Dr. Chambers. As for those of you who dialed in late, we did have some technical issues at the beginning, and we are a little bit late. So we will probably, if our presenters are able to stay with us, we will probably go a bit over time, past 12:30, 12:30 Eastern time, that is. So the last question we'll take for now is from Laura, and she's asking, when infants have several procedures during the day, is there a limit to the amount of 20% sucrose per day? And is there any evidence for increased risk of NEC, NEC, in association with using sucrose for painful procedures in neonates?
Okay, great. Thank you. Great question. And if there's not enough time to fully answer, I'm happy to respond offline. But in brief, we really don't know how much is too much. So the only evidence out there is that Celeste Johnson, quite a few years ago now, published a study that showed for those babies who received sucrose for preterm in their first week of life, 10 doses a day seemed to be safe, but any more than that seemed to result in reduced attention and alertness, but that actually did resolve itself again upon discharge. So that's really the only, and then Bonnie Stevens looked at these babies over a period of 1 month, so comparing the sucrose babies and the water babies who had sucrose for all procedures or water for all procedures over a month of life, but yet showed no difference in any neurological outcomes. But yet we do know that untreated pain results in, puts the babies at risk of adverse neurological outcomes. So it's really balancing. You know, we need to treat pain because that will help their outcomes, and sucrose seems safe, but really part of the big picture is reducing pain exposure as well, and only doing those blood tests when they're absolutely necessary, and promoting the maternal-led interventions. There's been absolutely no evidence that these tiny doses, they're 0.1, 0.2, 0.5 mils, so there's no evidence at all that repeated doses of sucrose result in NEC, which is a bowel infection for people out there who aren't familiar with the neonatal world.
Yeah. All right. Thank you. Great answers. So we do have a fair number of questions that have built up, but we'll move on to out to the East Coast with Dr. Christine Chambers out at Dalhousie University in Halifax, Nova Scotia. Over to you, Dr. Chambers.
Thanks, Doug, and thank you for the opportunity to present as part of this important webinar, and it's really an honor to be able to follow the excellent work of Dr. Stevens and Dr. Harrison. So I'm here today to present on usable evidence for procedure pain management in older children and adolescents, and really my presentation flows quite nicely from the two prior presentations. So I wanted to start with my case study just to get you thinking about some of the issues here. So we have a father who brings his 10-year-old son in for a flu shot, and he tells the doctor that he watched a YouTube video showing how topical anesthetics can be used to help decrease pain from procedures like flu shots. He asks if this is an option for his son, who has started to get quite anxious and nervous about needles. So two scenarios might possibly follow, and I'll get you to think about these. One is the doctor states, yes, topical anesthetic patches do significantly reduce the pain from injections like flu shots. I have one here, but if we apply it, you will need to wait about an hour before it takes effect and he can have the shot. Next time you can purchase one over the counter at your local pharmacy and apply it yourself before you bring your son in for his shot, so you don't have to wait. So that's one possible scenario. The next one is two. Those patches are really overrated and we don't usually recommend them. It's just a little needle and hardly worth the trouble and wait. It's better to just get it over with quickly. He's a tough kid. So I'll ask the audience to think about which scenario do you think is most likely?
Make your selection on the screen there of the two scenarios. Is the physician going to be supportive of using the topical anesthetic, or is he not, essentially? All right, so we can turn that around, and 90% of people are suggesting scenario 2, that the physician will not be overly supportive of waiting to use the topical anesthetic.
Right, well, and that's probably very true. This is a story that we've heard from many, many parents as I share with you some of the work that we've done. And moving on, in the second scenario, which 90% of you indicated would be likely, do you think the parents will, number one, would demand that his son receive the topical anesthetic or reschedule his appointment for another time so he can, or acquiesce and allow their child to have the flu shot without the topical anesthetic?
All right, we can probably turn this around as our audience gets more and more jaded, and 96% have said they just acquiesce.
Oh, dear. Well, and again, very, very possible, very likely. So I wanted to tell you a little bit about some of the work that we've been doing to try to change that. So my research program over the last 20 years has focused in the area of children's pain. We've been doing original studies and original discovery-based research on a variety of factors, many focused on psychological factors and family factors. Synthesis work, trying to summarize all the research evidence in different areas of children's pain. And also more recently, like Denise and Bonnie, really trying to take this research off the shelf and trying to make a difference for children with pain. And this is one of my favorite slides that was given to me a long time ago, and it's, even though it's the child here who's having the painful procedure or the needle, you can tell that it's the parent who's feeling the child's pain. And this slide really speaks to the important role that parents play and parent behavior can play in influencing children's pain experiences. And again, that has been the major area of my focus of my research over the last many years. What do we know about parent behavior and pain? Well, there were a number of studies that were conducted in the 1980s and 90s that videotaped children undergoing procedures and their parents and coded what kids did and how their parents acted and how these behaviors seemed to be related. And what all of that research found was that there were certain parent behaviors that are consistently linked with decreases in child pain. So we know these are things like non-procedural talk or using distraction, humor, so using jokes, or coping prompts like giving the child suggestions on how they can cope with pain. So again, not surprisingly, these types of things have been related to decreases in child pain. On the other hand, there were a cluster of behaviors that across studies and across painful procedures and populations were found to be related to increases in child pain. And these include, not surprisingly, things like criticism. If you criticize a child, they're not going to feel good, that's going to make their experience worse. But some of these were quite surprising: apologies, empathy, giving control, and in particular, reassurance. So reassurance, we know, is the number one thing that parents say when when their children are having pain, yet consistently it has been linked to increases in child pain and distress during procedures. A limitation of all of this research was that this prior work was all correlational. It was just looking at the relationship between certain things parents would do and then how children would react. And we did the first experimental manipulation of parent behavior during child pain in this early study of mine. We had mothers and 8 to 12-year-old children come into our lab, sit across from each other. Children took part in something called the cold presser task, which is a way that we can study pain in the lab. And unbeknownst to the kids, we had their parents trained to interact with them in one of 3 ways. We had one group of mothers who we referred to as pain reducers. They did all those behaviors that had been found to be related to decreases in child pain, like distraction and humor. Then we had a group of mothers who were trained to be these pain promoters, in which they were trained to do the things that had been linked to increases in child pain. So things like reassurance and apologies. So saying, it'll be over soon, that kind of thing. And so what we did in the study was then look at the impact of this maternal interaction type in comparison to a control group on the children's reactions to pain. And what this chart shows you is that we did find a significant effect for girls, such that mothers who acted with them in this pain-promoting way had daughters who reported more pain than mothers of daughters in the control group, followed by mothers of daughters in the pain-reducing group. But we didn't find an effect for boys. And so this was really interesting, and the sex effect is something we've explored quite a bit in our recent work. We know that children from a very early age receive strong signals from parents about whether it's appropriate or not based on their sex to show pain responses. And we wondered also if we'd had fathers take part in the study, if this would have impacted their behavior differently. But we were also very interested when we looked at what parents said. Again, reassurance, even though we trained them in a range of things, was the number one thing that parents did. And we found this quote from a children's novel that I think summarizes what might be going on. And it says, if an adult tells you not to worry and you weren't worried before, you better hurry up and start because you're already running late. So this quote signifies potentially the signaling function that parental reassurance might serve to children when they're having pain, that there's something to be worried or nervous about. And I won't share with you the details of the follow-up studies we've done over the years, but certainly our research has actually supported that children do sense or perceive their parents as nervous or worried when they reassure. So this is just one example of the kind of studies we've done in our lab to try to give us more information about what parents can say or do and how that impacts children. We've also had a broad interest in the role of psychological interventions to reduce pain. These would include things like breathing exercises, distraction, coping skills interventions. And my lab over the last number of years has taken the lead in summarizing the research evidence in support of psychological interventions for pain for the Cochrane collaboration. This was led by one of my PhD students, Lindsay. And we had an update published last year to this review in which we synthesized the evidence from 39 different trials for children aged 2 to 19 years. And we found large effect sizes for the efficacy of distraction and hypnosis to help children when they're having procedure pain. And I've noted a real problem with the quality of trials in the area, the quality very poor, which limits our ability to make a lot of conclusions about the evidence. We've done some follow-up work in a special issue of Journal of Pediatric Psychology that just came out, in which we showed that it really doesn't matter what type of distraction you use with older children and adolescents. Any type of distraction seems to be effective. All of our work synthesizing this evidence led to our involvement in the Help Eliminate Pain in Kids group led by Dr. Anna Taddeo, and she's been interested in addressing the problem of childhood vaccination pain, despite the fact, and you saw some of these strategies in Denise's presentation, that there's significant evidence in support of a variety of strategies for addressing pain during vaccination. Fewer than 5% of children get any kind of intervention or support or management for vaccine pain. So as part of this group with Anna, we helped to take the lead on summarizing the psychological evidence, and this table summarizes the interventions that have the most support for reducing pain. These were published in a clinical practice guideline in the Canadian Medical Association Journal, and we are currently in the middle of updating these guidelines and improving their applicability. And we've really tried to spread the word about the importance of vaccine pain management across childhood and adolescence. These are just some news stories that came out when the guideline was first released. We also contributed to an injection pain management sheet that's available on the About Kids Health website that families can download that give them practical tips on how they can put these tools into practice. And of course, I mean, I've been a pain researcher for 20 years, but I've only been a mom for 9 years, and it's been my own personal experiences as a mother. These are some photos of my children with some different interactions with the medical system, where I realized just how hard it is as a parent to advocate for proper pain management. There have been times where even I, as a pain management expert, and my husband, who happens to be an anesthesiologist, have had a hard time making sure that our kids get the good evidence-based pain care that they deserve. And this really worried me because I thought, what about all the other children who don't have parents who know what the evidence is and who feel comfortable advocating strongly for it to be implemented with their children? And so over the last 2 years, my focus has really drifted in the area of taking, again, this research off the shelf and making this evidence usable and actually accessible to parents. I completed a fellowship, as did Denise and Bonnie, through a group called the Mayday Fund that supports researchers and clinicians to become pain advocates. And we were successful in contributing to a cover story on needle pain management for babies in Parents Canada magazine. And there was also a wonderful piece in Maclean's magazine about children's pain, and I love the title, which says, "We're a leader in pain research, so why are there children suffering?" More recently, there was an excellent piece written about the problem of procedure pain management in children by Andre Picard at the Globe and Mail. This was published in October. And, you know, he directly challenged some of the myths that people continue to have about procedure pain management. There's a quote here you can see: "Suffering does not make kids tougher. On the contrary, it leaves psychological scars." But we also know from the research literature that it leaves physical scars and physical long-term effects as well. So like Denise, a strategy that we've adopted in the last year or so has been to embrace social media as a way to reach people with important evidence-based information about children's pain. Last November, we released a YouTube video for parents titled "It Doesn't Have to Hurt: Strategies for Helping Children with Shots and Needles." And in the video, this little girl that you see on the screen in 2 minutes shows what needles and shots are like from the child's perspective, and also gives advice based on the research literature about strategies that parents can use to help make needles better. And I'd encourage you all to please check out this video and to share it within your networks as well. And I was delighted to see what a positive response we've had to the video. We have a Facebook page for our Center for Pediatric Pain Research, and parents wrote things like, "My kids got their flu shots today, and the advice from your video made a real difference. It changed my attitude, so I was going into it pretty calm and not trying to convince them it would all be okay. And then distraction worked wonders. Thank you for the advice." So it was wonderful as a researcher to have an opportunity to interact with parents and to make information more accessible to them. This is a still from some of the tweets that we've had about our video, and it's one of my favorites. It's been wonderful to work with Morgan Livingstone, who I've never met in person, but we've been become buddies over social media in the last year. And she even took our video to Kenya and showed it to child life health workers there in the Sally Test Center. And so we were thrilled to see this kind of international reach of the work. So like Denise, we've tried to study not only the reach, but the impact of our video. You can see here some of the reach statistics. We had more than 26,000 views in the first 2 weeks, and the current total is greater than 82,000. It's been seen in over 120 countries. We did ask parents, what impact the video had. Like Denise, we had a very small sample size, but the data we did have showed very significant increases in the percentage of parents who were interested in using and applying the different strategies in the video. Again, Twitter has become a very useful tool over the last year to reach reporters. So the Andre Picard piece in the Globe and Mail came about as a result of some tweets that we've been sending. We've also reached out to colleagues across the country and child health centers and really tried to actively work together with mummy bloggers such as Erica M's Yummy Mummy Club to partner together to try to use their reach and our evidence to make a difference for children with pain. This is just one example of the kind of ways that we're trying to partner with individuals who have larger reaches. The Yummy Mummy Club blog, How to Make Getting a Needle Easier for Your Kids, in which she embedded the video that we produced. So that kind of gives you some highlights of some of the research that we've been doing over the last many years, and also some of our more recent attempts to try to take this evidence, make it usable, and make a difference for children with pain. This last slide of mine is just a still from our Center for Pediatric Pain Research website, where we have links to all of our videos and other resources for parents and health professionals if you are looking for some more information. But I thank you, and I look forward to your questions.
All right. Thank you, Dr. Chambers. Once again, fantastic presentation from all of our presenters, bringing such great information that really is what the reason we have such large audiences for these webinars that feature research on children's pain. Back during Dr. Harrison's presentation, we had a comment come in, and I held it off until after yours, Christine, because it sort of it ties into the scenarios that we had the poll questions about whether parents would advocate on behalf of their children or just bow to the wishes of the healthcare practitioner in front of them. Anne-Marie, and this sort of speaks to the international nature of our audience here. I believe Anne-Marie's from South Africa, and we have a number of other people from other countries in the world joining us today. But she said just a comment that the assertiveness of parents depends on socioeconomic status and culture. She says in South Africa, the majority of parents will just accept the decisions of the medical staff. And I think that stands true for not just South Africa, but many in Canada, and socioeconomic status and that relationship between the patient and the healthcare practitioner certainly plays a role in their willingness to assert themselves. But any comments on that?
Hi, it's Bonnie. I certainly agree with that. We've just been doing some work in Western Africa, and we are finding similar kinds of cultural influences. So I really think that we have to be cognizant of that, that some of the strategies that we may use with parents and healthcare professionals, where there's also a hierarchy, may not work in other countries. So I think we need to really listen to the partners that we're working with in those countries to find strategies that might be culturally specific and acceptable.
Yeah, I think that's such an important point, Bonnie. And I also think that, regardless of what culture you're coming from, the onus shouldn't be entirely on the parent. And that's why this is, a complex problem. Why aren't children getting the pain management they deserve? And certainly parents, play an important role. But as the excellent work you've done, Bonnie, over the years, addressing, the entire system, the health professionals, and, administrators, and taking a real complex systems approach. And I also think that the international applicability of a lot of what we're presenting does need to be given special attention. I know I'm going to the World Health Organization next month to talk about how we can modify some of the vaccine pain guidelines with Anna Taddeo that she's developed to make them more accessible and applicable to people around the world.
Yeah, thank you. And
sorry, go ahead.
Certainly, we need to target both ends. Like, we can't just ask parents to be the advocates in the face of resistance by healthcare professionals, but then again, we need to target healthcare professionals to work with parents and to provide and to give them the tools to provide the best evidence. So, the other thing that more and more is coming up from the from granting funding bodies is to have parents on our teams, and even children when it comes to pediatric research. So my Be Sweet to Babies team actually includes a family of children who work with me to help me develop posters and really put it into words, their views, so that gets their point across, and it just really helps to give them a bit more power than just saying, well, it's up to you to advocate for your child or for yourself. It's really bringing both ends together.
Dr. Stevens, we had a question come in during your presentation asking that you made reference to a pain toolkit that you were developing. Brenda's asking, is the toolkit currently available and is there any cost for it?
Well, we're actually still working on the toolkit. We have the first iteration of it, and we're actually hoping to pilot test that shortly. It will be available, I'm hoping, within a year or so, and we hope to have it web-based so that it will have many ways to be accessed. So unfortunately, it's not available yet, but we're working on it, and I hope it will be soon.
All right. Dr. Harrison, our colleague out in Edmonton, Dr. Samina Ali, is asking, do you have any thoughts on the use of breast milk as opposed to breastfeeding?
Yeah, sure. So the evidence from the systematic review of breastfeeding and breast milk for procedural pain management really shows that small amounts of breast milk are not effective at all. It's just not sweet enough. The analgesic effect is sweet taste on the baby's tongue, and breast milk has some sweetness, but it's very low. It's about equivalent of 8% sucrose, so it really doesn't work. So if you can get the mums to breastfeed, that is absolutely the best strategy. Or if the mum's not there and a daddy's there or an auntie is there, they can also do skin-to-skin care. So it's really promoting those strategies rather than using something that actually doesn't help that much.
All right, thank you. We have a question from Robin who's asking, do you have any research on the percentage of babies that may choke during breastfeeding during a blood draw?
Yeah, so in all the studies shown, there's hasn't been any choking observed as reported when breastfeeding. And certainly when I was a midwife, I was told as a very new student midwife, you just breastfeed the babies. Like, this is well before any evidence. Breastfeed the babies during the newborn screening because it helps. So I just said, yeah, fine, without really thinking about it. And, no baby choked. So the babies, and obviously the babies need to be well enough to breastfeed and breastfeeding. So certainly you wouldn't do it in a a fragile baby that's having their first feed, but the babies just keep on feeding, and I certainly show that very well in the 2 videos, so I'm happy to repost them. And you can see that the little newborn baby and the big 2-month-old, the 2-month-old baby certainly don't come off and choke or carry on at all. They just keep feeding. And the little 2-month-old baby comes off and has a little cry and then just goes back to feeding, no problem.
And we'll certainly put links to those 2 videos, which are on YouTube, but we'll put those on the Knowledge Exchange Network page where the recording for this webinar will be as well, so people can find those more easily. The next question is coming from Nettie, who is asking or stating that it would be very helpful to have German translations of all the videos at some point. So I'm not sure if that's on the agenda to do, but she's would be appreciative of a German translation.
Lovely, thank you.
Yeah. Gail is asking, are you able to administer oral sucrose to babies that have no suck and swallow? If you can give it orally, how effective is it?
Yeah, so that's a really good point. I mean, we really don't give it unless they have a gag reflex, but if the baby can have some sort of suck, we can give just a taste. So it's not even a ml or 0.1 of a ml. It's just a taste on their soother. But for babies who have absolutely no gag, no suck, no swallow, we really don't like to put anything in their mouth. More often we suction them to get rid of even small amounts of saliva. So it's usually not recommended.
Maybe I can just add to that. It's Bonnie. We're currently doing a study looking at the minimally effective dose of sucrose because in spite of all the studies that have been done, almost 60, as Denise said, there's still not really good evidence on the smallest dose of sucrose that you can give. So I'm not advocating that you could give small doses to this population, but I think these questions around choking and around the need to be able to swallow, etc., get at the fact that we might be able to do something that is a very tiny dose, a drop or so that's absorbed orally that might be useful for babies.
All right. This next question is for Dr. Chambers, and Sabina is asking, has any distraction technique proven to be more effective than others based on the current best evidence? Some techniques are much more expensive than others, so if we were making an investment, small or large, where should they put their resources?
Yeah, that's a great question, and it's exactly the kind of question we try to answer in our systematic review that just came out in the Journal of Pediatric Psychology. What we did was we took all of the distraction studies that have been published and then lumped them into what types of distraction were used. And yes, I mean the distraction can range from a free app on someone's iPhone or a pinwheel or something all the way up to a $20,000 robot. So there's a huge range there, and the data that we analyzed showed that there really wasn't a significant difference amongst the different types of strategies. But all that to say, there were not that many trials. As I mentioned before, the quality of trials in general in the area is quite poor, and also very few studies have directly within the study compared different types of distraction. So we really need more quality, prospective research directly, designed to address those types of questions, and also to include the very, like we're talking about, usable evidence today. So, including practical parameters like, how easy is it to keep clean, and what kind of maintenance does it need, and how cost effective is it? So the preliminary evidence that we've looked at says, no, it doesn't seem to matter what or how you distract the child, just that they are distracted. And the video that we have for parents promotes just using an iPhone, which many families have available, and letting the child play a new game or do something that way. But we really do need more research to investigate that further.
All right. And Dr. Chambers, another one, I think this question came in during your presentation. Karen is asking if you can clarify your meaning about the child having control during painful procedures being unhelpful. She's asking, right. Are you able to define this control? For example, like giving the child the opportunity to have to stall or be overwhelmed by choice or et cetera?
Right. So, that's another area where the control piece hasn't been investigated as thoroughly. In general, because, as a pediatric psychologist, we're taught, give the child control when it's appropriate. If there's a choice that could be made, give it to the child. The kind of control that the studies have examined that seems to be related to increases in child pain and distress is giving the child control when they're already distressed, and so they're not in a good frame of mind to be making choices, and so presenting the child with some sort of control or choice option when they're feeling stressed or overwhelmed doesn't seem to go over well, and that seems to exacerbate and make their pain worse. But that's a very good question. A priori, when you're trying to prepare a child, giving them as much say and control as possible, but it appears like actually during the procedure, trying to keep the sort of, decisions and kind of cognitive burden on the child to a minimum.
All right. This next question, and we're doing quite well on time considering our late start, so we will continue to go a little bit. We are past our usual finishing time of 12:30, but because we started late, we will continue with a few more questions as long as our presenters are able to stay on. This next question, we'll start with Dr. Stevens. To see if you have an answer for this one. Laura is asking if you can mix local anesthetic with vaccines, such as one does with ceftriaxone.
I'm actually not the best person to ask that. We would need our pharmacist colleague, Anna Taddeo, here to answer that specifically. I'm not sure whether, Denise, you would have an answer to that. I can just say I don't see that done at all, but I could be wrong.
Yeah, it's Denise, and I know it's certainly not in the recommendations, in the immunization recommendations. Again, I would have to defer to Anna as to why not. I mean, whether it's too late by that time, because the part of the pain is in the actual needle insertion, and there's no topical anesthetic, or there's no anesthetics at that point. So I don't think so, but let's ask Anna.
And Anna was in the audience, but I think she's left, so we can't even get her to put in a comment to give us some direction on that. So we'll have to follow up with her. But Deb is asking regarding the needle procedures. So we've been referring to vaccinations and needle pokes and that sort of thing. She's asking, would this include something as intense as Botox injections for children, for example, with increased spasticity? And I think this came in during your section, Dr. Harrison.
Okay. Most of the children certainly that I've cared for actually go for a light general anesthetic, because usually there's more than one injection. They're very deep. They're pretty painful. So something as small as sucrose is certainly not enough for more prolonged and more painful procedures. And so, yeah, it certainly wouldn't be enough. And as I said, most places that I know of, these children do have a light anesthetic, although I'd be interested in to see what practices occur in other people's settings.
All right. Can you give some sense of sort of the limit, the type of procedure that might give the audience sort of an idea of how intense a procedure these kinds of strategies would work for? So going beyond just a simple needle stick, how intense of a procedure could accommodate this kind of intervention? Well,
we certainly know that just sucrose alone is not recommended as sufficient for procedures like circumcision. So what is recommended is a nerve block and topical anesthetic like Emla or Amatop, as well as sucrose if you are going to do a circumcision. So sucrose is a mild analgesic and really only recommended for short-lasting procedures such as nasogastric, orogastric insertion, PIC lines, it has been used effectively for heel lancers, immunizations. But really, when you're getting even retinopathy of prematurity examinations, the evidence is variable. It helps, but it certainly doesn't totally reduce the stress and distress associated with those examinations. So it's a mild analgesic, and certainly for those, like for RAP, we need more. We need the topical anesthetic eye drops as well, and the swaddling. And even that, these babies still become very distressed. So we're not quite there yet in totally solving the problem of acute, even relatively short-lived procedural pain. The other thing with sucrose, the effect only lasts a very short time. In a young baby, maybe 5 minutes. In an older baby, only 1 to 2 minutes. So you need to repeat those doses for procedures that go on and on, for those IV insertions that are unsuccessful and the procedure takes 10 minutes. You will need to repeat the sucrose just in tiny drops. If you draw up a mil, just give it in tiny drops over the procedure. And again, this is something that really isn't actually well studied. It's just you will see that when you're the nurse helping or doing the procedure, that the effect lasts a pretty short time, especially once the babies are beyond the newborn period.
All right, thank you. So we had a couple of questions. I'll sort of read 2 questions here because there's been a few on this that have come in on this sort of topic. Michael has said, have any of these findings and evidence been added to the physician and nursing and other healthcare practitioners' curriculum to change the culture from the beginning? As we know, a large amount of learning is still on the job, and mentor-based and old school management may hold strong. And Allison, who's a child life specialist, also comments that she advocates for many of the pain management tools that were mentioned today, but she's constantly challenged by medical staff for evidence to show that this does not slow down procedures. So I think the question is, what's the best answer that people can give, whether you're a healthcare practitioner who has to stop the team or requests to stop the team to make one of these interventions and has to come up with the evidence to justify that request, or whether you're the parent who's advocating for their child for this. She says those who have seen it, and Allison goes on to say those who have seen it in action no longer need convincing. It's the results are obvious, but she says getting her foot in the room with some staff can be half the battle. So how do we go about changing the culture that might be resistant to this? And I'll leave that open to any of the panel to comment on that.
Well, it's Bonnie speaking. A lot of people, healthcare professionals, when you ask them where their evidence base is coming from for their pain management approaches and strategies, they'll tell you that it's what they learned when they did their professional training, so in nursing school, med school, etc. So a few years ago, one of my colleagues, Judy Watt-Watson, looked at the amount of pain content that were in various professional curriculums, and it was very minimal in nursing medicine. It was 5 times greater in the veterinary training. So, but I think that is changing, and I can only speak for the University of Toronto, but we have a large University of Toronto Pain Education Week that's multidisciplinary and includes 6 health care professional groups. So what we're trying to do is really get better content into the pre-licensure education so that people are coming out with better knowledge around pain. But other than that, I would suggest that you've heard today there's multiple sources of evidence out there that range from your more traditional published literature and presentations through to social media and casebooks and YouTubes. So I really think we're not dealing with a lack of available evidence. What we're really dealing with is the issue of how to use that evidence and access that evidence in a timely and relevant way.
Denise, Christine, anything to add to that?
No, I think, Bonnie's points are excellent, and I think that, it can feel a bit overwhelming or discouraging at times to be that one person in the room who thinks it should be going differently. And I think referring people to resources that are available, and I think there's more emphasis within accreditation standards and certainly hospital-wide based pain policies. So sometimes you can approach it from that angle. If you're not satisfied with the way children are, getting pain management for procedures and having challenges, maybe with particular health professionals on the team, then if you don't already have a pain policy at your center, maybe talk about putting a group together to have one. So as much as we can incorporate pain as a priority into accreditation standards, as Bonnie mentioned, licensing, so that we make proper pain management an expectation and not, optional.
And I guess I just have one more thing to add. Part of it is to working with the champions at the bedside. One thing we know is that if we effectively manage pain, the procedure actually takes less time. And nurses and physicians at the bedside are incredibly pressed for time. So we need to put that angle in through our champions at the bedside, and this is something that you really need to do there rather than write about it. And it's really showing the evidence. And so we know that if we reduce babies' pain, they won't be crying afterwards, they won't be compromising, dropping their heart rate, dropping their saturations, because hopefully they'll be much more settled. So you're not chasing your tail trying to settle a baby down or trying to calm a terrified child down. So we really need to put that up front, that extra time it takes to put these strategies in place actually saves time in the long run.
Carl is saying that Denise just made the important point that procedures take less time with good pain management. Is there any published evidence for that?
Unfortunately not. This comes from years and years of experience and observation, but it's a really good point. Like if we could certainly... I guess because the procedures, the studies that show procedure time are really only the time of the procedures rather than, that ongoing distress that babies and children have. We do know studies have been done from the oncology literature quite a while ago now that showed that for those children who don't have their pain treated during that initial lumbar puncture and that initial bone marrow biopsy, have much more pain and much more distress in subsequent procedures rather than if you manage their pain up front in that very first diagnostic procedure, then they have less pain during subsequent procedures. And that's really led to the very wide spread policies now of doing these procedures under a light general anaesthetic to make sure that we don't get these children into a cycle of more and more distress because they need a lot of procedures.
And Marianne put in a comment that says, where she says, decreasing pain in the patients and subjects also increases the nurse's sense of job satisfaction. Now, I'm not sure if that's from a published study or not, but that's certainly a comment that she's put in.
Yeah, thank you.
So I think the last question that we'll take, since we are a little bit over time, is from Christine, and she's mentioning that we focused on needle pain, but she's wondering if you have any suggestions for X-ray procedures or ultrasound in patients who present to the ER, as that was an issue that was identified at their hospital.
I mean, this is Christine. I think, briefly, a lot of the same strategies around psychological interventions and supporting children with relaxation and distraction are effective, not only with painful procedures like needles, but other types of necessary medical procedures or tests. I know there's a group here at the IWK that's testing out a really cool video game that kids can practice at home to try to train them to stay still during MRI. So I think this is an area where you're seeing more of a role of technology in assisting children through those other types of procedures.
All right. And I think we'll wrap the presentations up here. Thanks to the speakers for a great, excellent conversation following their presentations. Really some great information here. So we'll hand it over to our presenters for a final comment before we close off. So Dr. Stevens, do you have any final comments before we close off?
Well, I feel a little like a broken record, but I do think our challenge now is to take advantage of the wonderful research that people are generating and really think carefully about how we can take those results and make them into usable evidence and information for a variety of participants that care for children.
And Dr. Harrison, any closing comments?
Sure. So just going back to my tagline, so be sweet to babies and kids, and help nurses, doctors, parents, and the children really put pain management practices, effective pain management, into action.
And Dr. Chambers, anything?
Last but not least, I guess I would just encourage everyone that it starts with you. You've all, thank you all for joining us today for this webinar and for your interest in this topic. And hopefully because of your interest in this topic, you will share this information, go to our social media, our YouTube videos, share these in your networks personally as well as professionally so that we can all work together to make a difference for kids with pain.
All right. Well, thank you again. Just to close off, we've done a lot of work with our colleagues that have been on the line with us today, as well as many others that have been mentioned, like Anna Taddeo and others. All of that information is on our Knowledge Exchange Network that you can see on the screen. There's a section on children's pain where you can see some of the historical stuff that we've presented over the last few years, as well as I mentioned, the resources associated with today's presentation will also be up there. So thanks again to everyone for joining us. If you do have any other questions, a few people asked for Anna's contact information. If you want to just send me an email at dmaynard@cafc.org, I'll be happy to put you in touch with her. And if you have any other questions, don't hesitate to send me an email, and we can certainly connect you with the experts that you need to connect with. So thanks again for coming, our presenters and our audience. Sorry for the technical difficulties that started us off a little bit late. We do these webinars every Wednesday at 11 a.m. Eastern Time, and this was the first one of the new year, so that's perhaps why we had a few hiccups as we get back into the swing of things after the Christmas break. But we do hope to see you on our next webinar. Next week, we have Denial, Delays, and Disruptions, First Nations Children's Access to Health and Social Care Services, where we will be bringing some experts in to talk about some of the challenges that our First Nations communities have in accessing healthcare services and some of the differences that they are faced with. So we hope to see everyone join us on that one. And if you need any more information about our webinar series, you can always go to our website at cafc.org and the CAFC Presents section. You can always see the upcoming webinars. You can also find links to the previous webinars. As I mentioned, we always do record these. So if there's any parts that you miss, you can always go back and check out the recordings. So thanks again to everyone for joining us, and we hope to see you on the next webinar. See you soon, everyone.